Okay, well, welcome to this Target Trainer afternoon. So I'm Dr. Philippa Moore. I'm a consultant microbiologist here at Gloucestershire Hospitals Trust, and I work with the Public Health England Primary Care Unit. So we're going to go through the presentation that you would be giving to, or you will be giving to your colleagues, and obviously we'll have some discussion about it, and any questions that you want to ask about it, any clarification, then obviously please do put your hand up, and it would be worth asking because other people will have the same question, I'm sure, and we can record the answers. So the first slide in this points out that there are a few public health issues of potentially greater importance for society than antibiotic resistance. It's a really important topic. Hopefully you have already completed a self-assessment checklist over lunchtime, and it will be good for all your practices basically to have looked at that. So the aims of this workshop are to discuss some background to the Target programme, to look at some clinical cases which we could use to improve our antibiotic prescribing, tell you something about the Target tools that are available and on the website, show some of the evidence behind that, and you will get a bit more of that later on from Professor McNulty as well, and provide the evidence showing the link between antibiotic prescribing and resistance for your patients, show how reducing antibiotic prescribing can reduce antibiotic resistance. Okay, so if we don't tackle drug-resistant infections now, they could kill an extra 10 million people across the world each year by 2050. Now, the O'Neill report actually says that this is more than cancer and diabetes combined by 2050. That's how many people could die of antibiotic resistance. So it's a massively important issue, and obviously that's why it got up to the international summits. And we need to think about how we are going to tackle this. What can we do to slow that development of resistance? And it is driven by prescribing of antibiotics, and 80% of antibiotics in the UK are prescribing in the community in general practice. Some people think that an awful lot of antibiotics may be prescribed in veterinary practice. They are actually under pressure to reduce their prescribing, and it's not as much as it used to be. 80% in this country are prescribed in general practice. You can think about antibiotic resistance as being a bit like an iceberg. The tip of the iceberg is resistance to the antibiotics of last resort. So we think about the carbapenems, which are only used in hospital, have resistance to those. There's very little left to treat patients. ESBLs are now commonly seen in, for example, urinary tract infections. How many people here have seen ESBLs and urinary tract infection results? Yeah, a lot of you. We're seeing them much more commonly. And obviously, any resistance, for example, Staph aureus to penicillin, very, very common, and there's sensitivity. So you can think about it as an iceberg with the worst resistances at the peak, but an awful lot that's out there in the community. 7% of the general population in England in a 2014 survey had ESBLs, so extended spectrum beta-lactamases, carried in their gut. That means resistant to all penicillins and cephalosporins. So that's just people out there in the community. You can understand how important it is, how it's actually out there already and spreading. So it affects what antibiotics we can use as first line, and you probably know that trimethoprim, for example, is no longer first line for urinary tract infections because of the amount of resistance that's out there. This is a slide that shows just what proportion of antibiotics are actually prescribed out in general practice compared to hospital inpatients, dentists, other community prescribing or outpatients. So you can see how important it is to look at antibiotic prescribing in the community. And if we compare ourselves to other countries in Europe, you can see that we are slightly better than some other countries compared to, for example, Greece is at the far end of the highest prescribers, and they do have much worse resistance than we do. But you can also see that down at this end, this is the Netherlands, prescribe very much less than we do. And that says that there is an opportunity to reduce prescribing, because people in the Netherlands are not dying from infection as a result of this lower antibiotic prescribing. Their outcomes are actually just as good as ours. So that suggests that the difference between their prescribing and our prescribing is unnecessary prescribing. Yeah? So we need to look at ways that we're going to reduce it. So if we look at data from Gloucestershire, we can see that some of the antibiotics that are of most concern have and the prescribing rates that we've got for those. Now, why are those agents of most concern? It's because they're broad spectrum antibiotics, and broad spectrum antibiotics tend to select out resistance more. So you can get this data from Prescrip. It's a freely available website. The details will be given to you, and so you can look up data for your area, Northern Ireland, Gloucestershire, Herefordshire, wherever, and see how the prescribing is locally. And from the same website, you can get a scatter plot to show prescribing of particular antibiotics for practices, for counties, and have a look at the local target in relation to that. Data is also available from a website called Fingertips. And you'll be given these websites so you can go and have a look. Apart from anything else, it's interesting to see where your practices are in relation to the county and the country. So what about are there antibiotic prescribing targets? And the answer is yes. And if we look at what the prescribing actually is compared to what we think that the prescribing should be, you can see for a lot of these that we prescribe considerably over what we think should be the case. So, for example, for acute cough, the prescribing in this particular study, which was published in the Journal of Antimicrobial Chemotherapy, it's thin data, was 40%. And we think that actually, for all the people with cough, only 10% actually need antibiotics. For bronchitis, there's a huge pressure very often. These patients are smokers and they have had antibiotics before. 92% of people are prescribed antibiotics, and it's thought that only between 6 and 22 actually need them. So that's a massive area of over-prescribing. And you can read down the rest of the list there, 72 versus 54. Some of them, so for example, gastroenteritis at the bottom, they're suggesting that we may not be prescribing enough, or actually at the lower end of what we may be prescribing, so 4 to 16%, and that's absolutely fine. So we do well on a few things, but there are areas of definite improvement. If you think about sore throat and the media campaigns about the fact that sore throat antibiotics are not useful for sore throat, there's still way over-prescribing in that area compared to others. And we're going to look at that as a scenario for how we might think about reducing antibiotic prescribing. So just thinking about why do GP staff prescribe antibiotics? When you think about why are you doing it, you're wanting to relieve the patient's symptoms. You'll think about safety netting, worried about whether they may get more serious complications, more serious illness. And sometimes it's because patients ask for them. And data shows that when patients actually ask for antibiotics, it's actually very difficult for people to say no. And that's something that we need to think about. What can we use to help that conversation to re-educate patients who think that they need antibiotics when they don't? So, if we think about particular illnesses, we need to educate patients. Look at otitis media at the top line first. the duration of symptoms is between 4 and 12 days. That's anyway. If you give antibiotics, the difference it makes is between 8 and 12 hours fewer symptoms. So very little difference compared to the duration of the illness. The number needed to treat to get additional benefit to one patient is 18 patients, but the number needed to treat to get one adverse event is 9 patients. So in other words, by treating, you're actually more likely to get an adverse event than you are to get benefit. And the benefit you're going to get is a reduction in symptoms by 8 to 12 hours in the total course of the illness. Now, with that sort of information, you can see that actually, if patients were aware of this, they wouldn't be asking for antibiotics, where they're actually more likely to do harm than good. So we need to get this across to patients. We need to get to, you can see for the other scenarios there, it may not be doing more harm than good, but the actual reduction in symptoms compared to the duration of the illness is really very little. Sinusitis is a prolonged illness no matter what. 1 day of relief. Bronchitis, again, a prolonged illness, and up to 1 day of relief. So important that this information is put across, that you know it, your colleagues in your surgery know it, and patients know it. Okay. So if we reduce prescribing, is that going to be harmful? What's the dangers of that? In a practice of 7,000, if antibiotic prescribing was reduced by 10%, then what would that mean in terms of possible risk of events? There is a small risk, which in this particular circumstance, would be 1 additional pneumonia each year, 1 additional peritonsillar abscess every 10 years. So the effect of reducing antibiotics by 10% in a practice of 7,000 patients that's what you can predict would be the consequence. It's actually very little additional problems, admissions, people coming back with complications compared to the benefit of reducing that antibiotic prescribing and stopping the drive for resistance. So if we think about the complications, antibiotics and what may happen, serious complications are very rare after upper respiratory tract infections. With sore throat and otitis media, it's very uncommon to get a problem. Pneumonia is slightly more common, but more so in elderly patients. Antibiotics have very little benefit if there's no comorbidity. This bottom part of the slide is taken from the Public Health England antibiotic prescribing implementation tool that has basically information and advice not only on which antibiotics can be used to prescribe, the dose, the duration, but also of whether antibiotics need to be given or not. So antibiotics may not be given in a scenario of upper respiratory tract infections. If there's a risk, then a delayed prescription may be an option. Consider immediate antibiotics if the patient is very elderly, has been hospitalised, taking steroids, is diabetic or has heart failure, serious non-neurological disorder, or more than 65 with 2 of the above. And there are other things that can be used to help distinguish which patients may be the ones that are at most serious risk of having a poorer outcome. And that can be use of point-of-care testing with CRP. How many of you are in surgeries where you use point-of-care CRP? 1, okay. So not very many. I think it's something that I think will be promoted more heavily and is useful, because you can do a point-of-care CRP during a consultation. If it's less than 20, then the patient doesn't have a systemic illness, and you need to look at obviously the clinical history, but you can be that much more confident that the patient does not need antibiotics. 20 to 100, you would have a look at prescribing a delayed script, and greater than 100 to give antibiotics. So very useful test in order to safety net and be sure that actually antibiotics are not needed. So the Target website and the tools are there to empower you and your colleagues as you train them to be able to clinically assess carefully, to target treatment to those most at risk, to know about delayed antibiotics backups and safety netting, including provision of information, patient information leaflets. If we have a look at sore throat, there, for example, there's the fever pain tool, is an example of a clinical tool that can be used to identify which patients are useful to have antibiotics. And we'll go through some of those tools in due course. So Target stands for Treat Antibiotics Responsibly, Guidance, Education and Tools. It's a website that has a number of resources that are available. They're all free, can be downloaded from the website, accessible to everyone. These resources include patient information leaflets, posters for surgery waiting areas, and videos that can be put up about and that antibiotics are not necessary for certain conditions such as viral sore throats, audit tools, self-assessment checklist you've looked at, training packages, webinars, e-modules, antibiotic prescribing data, and the Target presentations. So there's a lot on the website. How many of you were aware of this website? A lot of you. You've all looked at it? Yeah, good. Okay, so if we think then, and go on to look at a sort of clinical scenario that you can use as a starting point in your surgery to think about how is your surgery going to reduce antibiotics. So let's go through the one that's there for sore throat. The scenario is a 17-year-old girl, 4 days of sore throat, fever, tiredness, cough, difficulty swallowing, temperature of 37.5, slough on the swollen tonsils, palatal petechiae, cervical and axillary lymphadenopathy, and she's had this before, and antibiotics helped her last year. Just in your perhaps tables, if in 2s or 3s, you'd like to just discuss who thinks that in their surgery antibiotics might be prescribed, what sort of way would the patient be assessed as to whether antibiotics were needed or not, and what resources would you use in your surgery to think about helping that patient? So I'll just give you a couple of minutes to discuss and we'll have some feedback. Okay. Shall we have a little bit of feedback? I can see some of you are looking ahead in the presentation already. Well, how many people think that antibiotics would be prescribed in their surgery for this scenario? Okay. Yeah. Okay.
And what time of day? What day of the week it is?
Right. Okay. Okay. So, are you happy to speak into the microphone and just say something about why there may be some differences within the surgery?
I think if they'd seen the doctor that they saw last year and they got antibiotics, they'd want to see that same doctor. I think if it's a Friday evening, they don't want to be ill over the weekend, so they would want antibiotics for over the weekend. Or if it was exam season, or all these different scenarios, really.
Yeah. And what about, I mean, do hand to a colleague, but do you think that there are differences between prescribers within the surgery?
Yes. Yes.
Yeah.
Yes,
Yeah.
definitely.
Okay.
Yeah.
So, has anybody addressed that? Has anybody thought about how to get consistency within a surgery? Does anybody want to comment? Have any of you got any tools that you're using?
We haven't got tools as such, but we take it to a clinical meeting regularly, and this is for nurse prescribers as part of our ongoing mentorship, this is one of the things we ask for, is that when we're doing the basic UTIs, upper respiratory tract tonsillitis, that we're all using the same Centaur fever pain, and we're also looking back at the history of notes and backing up. If it's clear that there's a reason why we haven't prescribed them, that's fine. If we should be prescribing, that's fine as well. But back the decision up, don't just overrule.
Yes, okay. So I might have used the wrong word with tools there, because I would say Centaur and fever pain are tools to be used, as indeed having a practice discussion to go over patients to actually ensure that you're thinking in the same way and having consistency is actually really an important, I'm calling it tool, but whatever you want to call it. Yes. Anybody else got any comments on this? Oh.
I think that you see a difference when you have GPs that work in the out-of-hours scenarios to GPs that work in general practice, and you'll get a tendency for the GPs in the out-of-hours to be using the fever pain and the Centaur scores, whereas some of the older, mature GPs from general practice will tend to use their own sort of skills of experience and not necessarily always the up-to-date clinical skills required.
Right. Has everybody heard of the fever pain score? So a 5-item score based on fever, purulence, rapid attendance, so how long is the history in the patient, whether there's severely inflamed tonsils, and no cough or coryza. And the patient above scores a 2 on that score. So a lot of the scenarios that are put in for the target website are deliberately designed to be on the edge. So not a clear-cut no antibiotics, and not a clear-cut you should give antibiotics, but right there in that grey zone in the middle. So you'll find that with all of the scenarios that you can use. In this setting, a fever pain score of 0 to 1, only 13 to 18% have streptococcus, and the fever pain score is not just looking at group A, it is looking at other causes of sore throat, C's and G's, and it's why it's a useful tool. No antibiotics for a fever pain score of 0 to 1, whereas 2 to 3, 30 to 40% have a strep throat. So it's appropriate to consider a delayed antibiotic script after appropriate discussion, because obviously the patient has to understand what that means. Whereas if the score was over 4, then 62 to 65% have patients have a strep throat, and it would be a consider immediate antibiotics, particularly if the symptoms are severe. Or the other option would be go for a very short delayed prescribing, up to 48 hours. So there is a website for the fever pain score, which you can then go in and score the symptoms, put whether there's fever there, and it'll calculate the fever pain score for you. And you can then record this in the patient's notes. So that's very useful, and you can go to the website. And how many people knew that there was this website? Some of you, but not all of you.
It's very much linked into templates.
Right.
So before you prescribe it pushes you to do it. Which is
Yes,
great.
okay.
Yeah.
Great. So certainly if anybody is not aware, then have it. Now, are there any surgeries that still prefer Centaur? Yeah. Okay. So the pack here has a way of looking at Centaur score for this particular scenario. So again, it's still a scenario that puts you right in the grey zone for the Centaur criteria, but you can use that if in your surgery you'd actually rather stick with Centaur. Then again, you can just take the fever pain score out if you want to, and use slides that are all about Centaur, and you come to much the same conclusion. So the PHP antibiotic prescribing implementation tool, formerly known as guidance, has information about self-care, about when to think about giving antibiotics, about the scores, when to think about delayed antibiotics, and if treatment is going to be given, then which antibiotics to use, which doses, what duration. And in all of the guidance, where you've got these bits on the side, these are hyperlinks that take you to the evidence. So if you're wanting to know further information, then that's how you can go into them and get to information, or they take you to an appropriate website, such as the Fever Pain website. So that's just useful for you to know when you're looking at the Public Health England websites. And they have algorithms for looking at whether you should treat or not. And again, different people obviously prefer to get their information in different formats. So if algorithms are what your practice prefers, then that's an option as opposed to just writing. And you know, for some people that can be useful to be printed out and put on a wall. Although obviously there's plenty of scenarios, but you know, sore throat is common. What about the evidence for backup or delayed prescribing? I really like this particular study, quite old now, published in 1997. But they basically, this was an English randomised controlled trial comparing 3 treatment strategies for sore throat. And you can see nearly 600 patients involved. When you look at patients who were given antibiotics, which is the red, given no antibiotics, the green, or given a delayed script, the yellow, you can see that those who got better, no significant difference between any of those, whether they're given antibiotics not or a delayed script. In terms of patient satisfaction, no difference. But where there is a difference is where the patients think that antibiotics are effective. If they're given antibiotics, they think they're effective compared to those not given them or given a delayed script, and who would come back to their GP again if they had similar symptoms. And that's, again, significantly more if they're given antibiotics. So prescribing antibiotics increases your workload effectively, because patients are more likely to come back and want more antibiotics next time they have the same condition. Or the reverse side of the same coin, you know, you can reduce your practice's workload by teaching patients not to expect antibiotics, not to have antibiotics, so they don't come back next time they have that same illness. So I'm aware all practices are, you know, swamped at the moment and very overworked. So as a strategy to reduce your workload, reducing antibiotic prescribing is a good one. And there's no difference in outcome. So, does it work to give a delayed script? Some people sort of think, well, if patients are given a delayed script, then they'll just go around the corner, cash it in straight away and take the antibiotics. In fact, there's very good data on that, and this is the data you can show, which shows that in a huge study, so this was 3,385 patients, more than 15 years old, 5% were offered backup or delayed prescribing in the past year, and of those, only 57% took the antibiotic. So therefore, delayed scripts can reduce antibiotic consumption by about 40%. And that's those who've cashed in their prescription. Actually, there may be those who've gone and got the antibiotics, but then still decided, well, let's actually wait and see whether I actually take them. So those who've cashed in prescription, it's still a significant reduction. And what do the public think in terms of delayed prescribing? So this was a study done in 2014 by Professor McNulty that showed that basically, if you look at 2014 and 2017, of those who were in favour of delayed prescriptions, there is an increase in those either strongly in favour or tending to favour. But there's quite a substantial proportion of people who still don't know and some opposition. And so what that says is that there's a lot of room for further education. But you can see the increase in people tending to favour says that, you know, some of that education is going on and patients have taken it on board. So, you know, useful to do. A thorough explanation of the rationale and also how to collect the prescription may be needed for some patients. And in terms of how to collect prescription. There are obviously different ways of thinking about delayed scripts, whether they are given at the time of the consultation and a patient has said, cash this in X number of days if you still feel unwell, whether it's come back to the surgery, pick up a prescription if you still feel unwell, or here's a prescription but I'm going to put post-date it so that you can cash it in only in a few days if it's appropriate. And in terms of the duration of the illness, the belief in the effectiveness, the outcome, there's no significant difference. The strategy is used. So actually whichever suits your practice best can be used. For those who are not given antibiotics or not given a prescription, there is this no prescription prescription leaflet. So this is available from the Target website. You can download it. These are all free. It's the sort of thing that you may want to have a stack of them printed before so that you can use them on patients. So they can be personalised, they've got the patient name in them. You can see here that it's, what sort of infection are we talking about? What is the likely duration of the illness, which is very useful for patients to know, particularly for the longer ones. How can a patient look after themselves or family? And safety netting information, if things get worse, what are the things to look out for? And then information about antibiotics and coming back to get antibiotics if need be. You can see on the bottom that there's an awful lot of societies involved in the development of this. There's a lot of buy-in with this leaflet, so a well-researched, useful one to use. Not only available by Target, but also if you put in these codes, it's available on System 1 and EMIS. And there is a read code for a delayed antibiotic prescription. There are also posters that can be displayed in your surgery. So these are downloadable again, printable, and you may recognise some of them. They've been around for a little while, but again about educating patients. So a lot of patients know now that taking antibiotics unnecessarily is not a good thing, but it's useful to reinforce that message with either posters or videos in the patient waiting areas. How many of you have you got television screens that you can put videos on? So this is one of the things that could cycle through. And then there are also patient information leaflets about particular conditions, but also generally about taking antibiotics. Again, all resources on the same website. Okay, so we're just going to now take a little bit of time to think about action planning. If we're particularly thinking about sore throat, what would you do in the next 12 months in your surgery? Okay, so I'm going to interrupt you here. I know you've haven't had very long to think about it and you will need more time, but shall we try and sort of just get some feedback about what people have thought about doing? Can I suggest that if I start from this end and just give me something that one thing that you've thought about doing, pass the microphone along and we'll go around this way.
So I suppose we were talking for Northern Ireland as a group of practices. We're talking about the idea of a template on the GP practice systems. If you can get a template that automatically directs every GP in the practice to an action, and also then within that template, if it read codes back no antibiotic, that's important to capture as well. The fact that we always go after GPs because they're prescribing, but we want to see no prescribing as well. Yeah, good. Okay. Pass on to the next one.
Thank you. I'm not sure whether does anybody have the Arden's templates on? Do they? Are these on there?
Yeah,
Can you? Yeah. So that would be brilliant because that would show up on the record and you'd be able to click into it. So that would be very helpful, I think. Yeah. Mhm.
before you prescribe, and then they discuss
Yeah.
your score.
Yeah, brilliant. So that'd be brilliant. I think the other thing we said was bringing this to a practice meeting and everybody discussing it really, and presenting the evidence.
Yes, I think convincing the whole team and getting everybody on board.
The other thing is discuss other drugs that you might use, like a diflam spray or analgesia, and then review them. So if they're not picking up, then you've got the option of then going back to antibiotics if you need to.
Yep, okay. So a strategy for reducing antibiotics by using other medications. Yeah.
And everybody's singing from the same song sheet.
Yes, yes.
We already have an audit just about to happen, following on from today, which I
Right.
lead, and a bit on UTIs.
Okay,
so
yes.
It'll be a follow-on from when we had 3 months ago, so that will tie in with the second bit here.
Yes, okay,
'Cause we need
okay.
to sort of tighten our bells up a bit
Yeah.
in stride.
Okay, so
And we said about using the resources provided on the Target website,
Yep.
such as the leaflets for sort of self-help, giving
Yes.
sort of that prescription as opposed to a medical prescription to give to patients to take away for them to sort of help themselves.
yeah, yep, good.
We talked a little bit about the project we're doing with some of the surgeries where we're working with the patient participation groups. And it's still too early because we want to see if by working with the patients they'll understand better what we're doing.
Yes, so patient participation groups are a very, very good idea.
I was just wondering if all the clinicians were aware of the delayed prescribing read code. I thought if they knew about that, then maybe it would just make them think more that delayed prescription might be a good idea.
Yeah, yeah.
So just sort of flagging that up, and actually then you might get more interesting data when you're looking at the audit.
I discussed the read codes with Maggie for the delayed prescriptions, which I don't think could be used in our surgery.
Right, so definitely an opportunity there. Yeah.
I think we discussed most of what everybody else has discussed as well. The only other thing to add is that I would go back and say target our waiting room areas with posters, campaigns, and just ensure that we're up to date with it, because they sometimes get a bit tired and jaded.
Yes,
So.
yeah.
And I thought that maybe before doing anything, actually going back to look at your prescribing habits and see where you actually are statistically compared to the national average might just give you a little bit of backup, either to see we need to change this, or we're actually not doing too bad, but
Yeah.
you know, let's look at how we can continue to improve.
So using the press quip and the fingertips data, yes.
Yeah.
Yeah, same as everybody else has said already, really.
Okay.
Add to that possibly some way that the patient knows if they are getting worse, that they've got a way they can recontact you rather than thinking, oh, I'm going to have to try and get another appointment. So maybe have a certain time of day when they know they can try and ring you and get hold of you just to say, I am getting worse, or I have got problems, rather than them trying to have to go through out of hours, or you know, the sort of things that concern them.
Yes, so having a plan to reduce out of hours contact.
I think this slide about the evidence of antibiotics delayed prescribing is really powerful for the sceptic GPs, and I think that would be my starting point.
Yes.
And then pull in all the leaflets and the tools from Target, but I think that's incredibly powerful.
Yeah, yeah.
Yeah, similar things to what have already been discussed, use of the tool to standardise practice.
Yep.
Just more education generally, patient and doctors, nurses, all of us.
Okay, great. Well, thank you very much for that feedback. And I put a few things on the screen there as options, but also, in fact, the team have also put together an action planning sample, which Donna will just hand out, and if you take one and pass it along, you've done that already, okay. So you've got an option for a ready-made action plan there as well. Okay. We all ready to move on then and think about another clinical scenario? Urinary tract infection. Huge area of prescribing. Okay. So here is another clinical scenario for you to think about. We've got a 35-year-old woman with strong smelling urine, dysuria over 2 days, frequency. She's had a recent laparoscopy and removal of endometriosis. She's had trimethoprim in the past month for suspected UTI post-op. What questions should you ask? What happened to the microphone? Sorry, thank you. Okay, does anybody want to put their hand up and think, what questions should you ask this woman?
Does she have a discharge?
Yeah.
Does she have vaginal discharge?
Okay, so does she have vaginal discharge? Thinking about alternative diagnoses. Anything else?
Does she have a fever?
Okay, yes. Does she have a fever?
Any pain?
Pain, particularly.
Loin pain.
Yeah, so you're thinking about a differential diagnosis of pyelonephritis. Yep. Anybody else? Okay. Okay, again, other symptoms that might indicate something more serious, such as pyelonephritis. Yep. Yeah. Was the sample taken? Is it on? Are there results to look at previously? And what apart from failure with previous treatment, what other things might sort of flag risk of resistance?
She's had lots of times in the past.
Yes, a history of recurrent UTI. And anything else? Think about one of the previous slides, one of the very early slides I showed about antibiotics.
The level of resistance to coming.
Well, there is that, yes. But in terms of what you would ask her, okay, we're in summer holiday season. Does that give you a clue?
Has she been abroad recently?
Has she been abroad recently? It's a good question, because if she's just come back from a holiday in Greece or Turkey, then the chances of her having something more resistant, would be higher. Travel is associated with antibiotic resistance. So there's symptom severity, duration, other symptoms such as nocturia, hematuria, so non-UTI symptoms, pyelonephritis and issues about resistance. Yeah. So PHE have developed a diagnostic flowchart. It's currently out for consultation if anybody wants to comment on it. So this is the one for women under 65 years old with suspected UTI. Prompts questions, so things that might suggest a non-UTI diagnosis, and take you to down a different route of diagnosis and prescribing. Are there any risks of sepsis? Something that might prompt either admission or certainly immediate antibiotic prescribing. And then how many symptoms has the patient got? How likely is it that this patient has a UTI, which then takes you down the algorithm of whether excuse me, whether you go for immediate antibiotic prescribing or might consider dipstick testing if you're not sure, with a view to improving the likelihood of a diagnosis or not a diagnosis, and then thinking about whether the patient should have antibiotics, whether you should be sending a urine for culture, what information you should be giving the patient, whether you should be giving them an antibiotic or not, and giving them a UTI leaflet about self-care. One of the things I think is most important, and it's particularly at this time of year, is to think about hydration. There is a peak of E. coli bacteremias every summer, and it's associated with UTIs and dehydration. So hydration is really important. So anyone who has had a UTI then should be given information about hydration. And certainly here in Gloucestershire, we're about to have a campaign promoting hydration over the summer. So why do we need to worry about antibiotic use in UTI? There was a study that looked at antibiotic resistance and how the use of antibiotics was affecting antibiotic resistance. So this was a prospective study. You can see nearly 500 women with UTI symptoms. And basically, what this study showed was that if the patient had a urinary tract infection that was resistant to the first-line antibiotics given, then the symptoms were there for longer. The patient was more likely to come back and reconsult, to have further antibiotics and not to be cured. So the presence of the resistance was increasing the workload, as well as causing more antibiotics to be prescribed. Okay, so it's patients coming back to your surgery. So we want, where possible, less prescribing. The evidence in terms of previous antibiotic use and subsequent resistance is shown in this slide, that basically shows that if you use antibiotics, then you increase the chance of resistance to that antibiotic. So I don't know how many of you are familiar with treating people, women with recurrent UTI, but you can see a progression over time where they tend to get more and more resistance as they've had more and more courses of antibiotics. And you can see that sort of anecdotally, but there is also data backing that up, showing that if you take any antibiotic, and this is antibiotics in the last 6 months, there's an increased likelihood of resistance. It's important for women to know this, because actually if their symptoms are less certain, they possibly may not need antibiotics now, then it may be better for them not to have them, so that they're not driving resistance and potential treatment failure in the future. Longer duration of antibiotics increases the risk of resistance. Multiple courses also increase the risk of resistance. And this study showed that basically the chances of having a resistant organism, if you've had any antibiotic in the past 2 months, in this study there was a 2.5 times likelihood that your treatment for UTI would fail because of antibiotic resistance. And what's important to note is that this resistance, probability of resistance carries on for 12 months. So any course of antibiotics is effectively increasing the chance of subsequent resistance for a year after that course. This is the downside of antibiotics. This is why patients shouldn't have antibiotics when they don't need them, because of this resistance. Because, for any patient who is sitting with you on any particular day, what is going to happen to them within the next year that they may need antibiotics for? And that's the conversation to have. Well, do you need antibiotics today, or do you want to, if you like, save your course of antibiotics because you might need something within the next year? It's something for patients to consider. The data on trimethoprim shows that there is a substantial increase, getting up in the elderly age group towards nearly 50% resistance in this study that's actually from the Welsh Antimicrobial Resistance Programme. And it's the over 80s that have got those very high levels of antibiotic resistance, because those are the ones getting more prescribing. And this has prompted the change to nitrofurantoin being first-line antibiotic now for antibiotic for UTI in women. And if we look at the data in a similar data in a different way, basically you can see that the resistance to trimethoprim is much higher in women than it is in men, and so that reflects obviously the fact that women are much more likely to have UTIs than men are, and so there's that clear correlation between antibiotic prescribing and the resistance that you find. And if we look at however it's measured, basically in terms of that's tested against trimethoprim and the percent non-susceptible to trimethoprim. If we look at nitrofurantoin, Then there is also some resistance. You can see that the resistance is much greater in the elderly population here than it is in younger people. But as prescribing increases, so we will drive resistance inevitably. So this is going to be problematic in the future. But at the moment, there's much less resistance than there is to trimethoprim. If we look at ciprofloxacin, which people often reserve as an antibiotic that we use less commonly, and we try not to use its broad spectrum, but you can see there already is quite a lot of resistance to ciprofloxacin out there as well. Again, much higher in women than it is in men, reflecting a much higher in the elderly age group than it is in the younger ones. With the changing guidelines, we can see that the antibiotics are prescribing is changing across the UK. So you can see that trimethoprim prescribing is going down and nitrofantone's prescribing is going up, which is, in line with the changes in antibiotic guidance. So there is a very useful patient guide in terms of patient information leaflet for urinary tract infection. Gives people information about possible urinary symptoms, about what will happen in terms of if you've got mild symptoms, antibiotics less likely to help, recommended self-care, an explanation of types of urinary tract infection, so people can sort of understand where it's all coming from. So that's those. Self-care and safety netting advice, which is also on the leaflet, where to get help, when to get help, and how to prevent urinary tract infections, which is also very useful given the number of women that get urinary tract infections. It is important about trying to prevent for the future. You have the opportunity particularly for hydration. And then there's a flow chart to help patients understand antibiotics and resistance. So with urinary tract infection, you might imagine that the general public may not be in favour of delayed antibiotic prescriptions for UTI. But in fact, what we are seeing from the data shows that actually there is an increased acceptance of delayed prescribing for urinary tract infections. And again, so this reflects people using delayed scripts and educating patients. So there are still a number of people, however, who either don't know or are against delayed prescribing. And again, this suggests that the opportunity is still there for a lot more education. And this is the data to sort of support that and say, actually, we need to educate our patients. Look how many don't understand delayed scripts. Okay, have another think about this scenario. And I suggest this is more complicated. So I'm going to give you a couple of minutes just to discuss again among yourselves. This 80-year-old resident in a nursing home, strong smelling urine but looks clear, increasing confusion over 2 days, positive dipstick, no history of fever, and has had antibiotics in the past for suspected UTI. What would you do? How many would be recommending antibiotics? What would you think about this? In the interest of time, I'm going to interrupt here and just sort of ask you to come back to me, and what sort of things would you ask about, or have you all looked at the next slide? So I've put that up. There's a number of things to think about in this patient. Worsening incontinence frequency, suprapubic pain or flank pain, hematuria, hydration. How well is this patient hydrated? Don't forget we're talking about strong smelling urine but clear looking. So is this actually just really all about dehydration, which might in itself be contributing to confusion? I mean, it's a very common scenario where there's an assumption of UTI, and it's obviously driving a lot of prescribing. How many, hands up, who would do a dipstick? Or would have done a dipstick? You would, okay. So asymptomatic bacteriuria in the elderly is very common, and that will lead to there being positive dipstick results. So the new guidance is actually not to do dipsticks. Now, we can talk about previous antibiotics, but the criteria for initiating antibiotics are around acute dysuria, fever, and one or more symptoms of worsening urgency, incontinence, new incontinence, frequency, basically urinary tract infections, and to go with these clinical criteria rather than using a dipstick. Okay, so dipsticks are no longer recommended in the over 65s. The first line treatment would be nitrofurantoin for 3 days as a simple UTI, but it's really important that you have got the history of what has happened in the past, because if this is someone who's prone to recurrent UTIs, has happened in the past, then actually it may be that there's a known history that they always actually need 5 days of antibiotics to cure their UTI, because as patients get more elderly, immune system fails, sometimes people need to have longer courses when they're elderly. So actually having that history is very useful. Plus, of course, having a history of whether they are sensitive or resistant to nitrofurantoin. Bear in mind as well that elderly patients may have reduced renal function, and if the EGFR is greater than 44, then you can start treatment, and if it's less than, you shouldn't be using nitrofurantoin. Okay, you should be thinking about alternative antibiotics to use. There are other causes of confusion, and the PINCH-ME acronym, which there's information on, is a good one to use to think about other causes of confusion. There is a diagnostic tool for older adults, so adults over 65. Again, localised symptoms, thinking about sepsis, and considering pyelonephritis before considering as to whether you need to treat or not. PINCH-ME, I mentioned pain, other infection, poor nutrition, constipation, poor hydration, medication issues, environment change, and these may all be reasons for the increase in confusion. So useful flowchart that can be promoted for antibiotic prescribing, and potentially if your practice is one that looks after a number of care homes, it may be useful to go out and educate the staff in the care homes, because I'm aware that sometimes what happens is a nurse from a care home will phone up and say, this patient's got a UTI, could you prescribe some antibiotics? And there really isn't an evaluation of how likely the diagnosis is. And if that tends to be what happens in your practice and the GP is just sort of signing the scripts, then think about whether these sort of tools should be promoted in the care homes. So in terms of antibiotic resistance, there's a lower risk of resistance in young women with acute UTI as opposed to recurrent UTI, no resistance risks, but you've got increased risk of resistance if you've got a care home residence with recurrent UTIs, with unresolving symptoms, recent hospitalisation, travel to countries with high resistance rates and previous resistance. And if there's any doubt, you should have a very low threshold for sending off a urine for culture. Then the question over whether or not the diagnosis is likely, again, it's useful to do that. I think, my own opinion on this is there will come a time when resistance is so common that we actually need to send a urine every single time, because you are going to be unable to predict sensitivity. So low threshold for sending urine. As prescribing of broad spectrum antibiotics has reduced, there is data to show that the blood culture isolates are less resistant. So this data is useful to where people are thinking about prescribing, and you're thinking about, well, is it actually going to do any good, all of this reduction in prescribing that we're talking about? Well, yes, there is data to show that we can actually reverse some of the trends. So that is very useful for people to know. And what about C. diff, which is the other issue? In terms of C. diff, 60% of all C. diff diarrhoea is now community acquired, obviously associated with any antibiotics in the past 4 weeks, particularly certain sorts of antibiotics, particularly with the commonly used antibiotics, the beta-lactamases, amoxicillin. The cephalosporins have always been known to be high risk, and I think co-amoxiclav is a high-risk antibiotic, and it really is depending on how much is used in any particular place. Multiple antibiotics are also particularly high risk for C. diff. We've always known that clindamycin is a particularly high-risk antibiotic. Tetracycline is not. So that green little dot there is, something to flag, as tetracycline is not associated with an increased risk of C. diff. Are they really protective? And I think it's difficult to say, but there's that possibility. So reducing broad spectrum antibiotic prescribing will reduce C. diff in the community. And those broad spectrum antibiotics that we're wanting to particularly target are ciprofloxacin, the cephalosporins, and co-amoxiclav, all of which may be used for UTI. And we're wanting to increase the use of nitrofurantoin, and pivmecillinam is another narrow spectrum antibiotic, narrower, not narrow, but that has less association with C. diff and is useful nevertheless for a number of organisms that are multi-resistant. So we will see an increase in the use of pivmecillinam, and it is something that increasing the labs need to provide sensitivity data for that antibiotic. Trimethoprim is still good for UTI in younger patients, because you've seen the data for the resistance is very much weighted towards the elderly population. And there may be sensitivity in younger patients, or particularly who've not had recurrent UTI. In terms of the antibiotic guidance or the recommendations that PHE have, co-amoxiclav is actually only recommended in certain scenarios: pyelonephritis in pregnancy, facial cellulitis, prophylaxis post-bites, diverticulitis, and a second-line treatment for persistent sinusitis. So the indications for co-amoxiclav are actually relatively few. We've seen a lot prescribed in hospitals recently when there are other antibiotic shortages, and we are now trying to turn back from that because it probably has driven some of the C. diff. So there is a required performance QP in 2018-19, and that is for a reduction in E. coli bloodstream infections. Why is that relevant? Well, it's because an awful lot of the E. coli bloodstream infections are related to urinary tract infection. So if we're going to reduce the urinary tract infections, then we have to get better at diagnosing and managing urinary tract infections in order to affect the E. coli bacteremia rates. So there are quality premiums associated with that, which you may be familiar with, and certainly the information is all there for you. The reduction in the target of E. coli's 10% of reduction is 20% of the weighting, 15%, 25% of the weighting, 20% reduction, 30% of the weighting. And there's an aim for a 50% reduction overall in bacteremias. And a reduction in the number of trimethoprim items prescribed to the over 70s, and it is useful to know it is in the elderly age group, and a sustained reduction of inappropriate prescribing in primary care over the top. And you can use the fingertip data to see how your practice is doing in relation to prescribing using basically you've got the website there. Okay. Now, there is now a urinary tract infection leaflet for older adults. I showed you the one for younger ones earlier. So this is available. Again, it's got a useful colour chart for the colour of urines and hydration. You may find that in areas that there are things like called drinks trackers which are promoting hydration. Hydration is really important in the elderly for the prevention of urinary tract infections. Information on signs and symptoms, other causes of confusion. Self-help information, information about what a doctor or pharmacist might do, about advice on antibiotics, and safety netting advice and when you should get help. And again, this is a easy read, reasonably easy read format. The Target website has audit templates for urinary tract infection, exactly as before, with the audit tool there for you, and will calculate your prescribing. And there are training packages for managing urinary tract infection. So we're going to have just a pause there for a moment and have a think about what your practice could do to improve prescribing for UTI. So again, if you've got one of the templates in your pack, have a think about what you might put in that template for reducing prescribing for urinary tract infections. To give you a few minutes. Okay, well, thank you very much indeed. So there's a few things up on the screen there, and again, PHE, have you given out that? Yes. So you should also have a prompt to consider. Okay, there are some UTI action plans to pass on and keep. So you can take those back. Okay, so I should think you're probably all in need of a cup of tea. So just to wind up, in summary, reducing antibiotic prescribing in your practice makes a difference to antibiotic resistance in your patients, is slowing the drive of further antibiotic resistance for the future, reduces your workload in terms of reducing consultations, and empowers patients to self-care. So it has multiple benefits. And we need to think about how we can put together the GPs, their prescribing, the practices, the evidence and the patients, putting it all together as a jigsaw, and all of the resources on the Target website are there to use to help do exactly this. So hopefully you can go away from this with ideas of what you're going to do in your practice, particularly over the next 12 months, and to come back and feedback. So we want to improve antibiotic use. in 2010 but also in 2018, I would suggest. Halve E. coli bacteremias. We've got various tools by which we can use to do that. Use the fingertips and press grip data to look at your surgeries, to use the leaflets, to develop computer prompts to increase the use of the leaflets, use backup and delay prescribing, refer to the posters, make sure everyone has access to the antibiotic guidance, and think about an antibiotic audit with action planning and redoing the audit. And you need to decide who will be responsible for each of these actions so that they don't get lost as you leave here today. Okay, well, I hope you've enjoyed the session, and thank you very much for your participation. I think you've earned some tea, and please do send in some evaluation. Thank you very much.